Hypopituitarism may present as isolated growth hormone deficiency or with multiple hormonal deficiencies, that is, pan-hypopituitarism. The typical causes of congenital hypopituitarism are gene mutations, where we often see a positive family history, and anatomic abnormalities, that is, hypoplasia, aplasia of the hypothalamus and pituitary. In congenital isolated growth hormone deficiency, we see this resulting from deletions in the growth hormone gene, which can occur as either autosomal recessive, dominant, or X-linked inheritance. There can be receptor mutations, or even an abnormality in the insulin-like growth factor gene or binding protein or its receptor. Acquired causes are any lesion then, such as a tumor, infection, trauma, vascular or hypoxic problems that damage the hypothalamus and or pituitary. This usually presents with multiple hormonal abnormalities, and the most common cause of this is the craniopharyngioma. With respect to congenital hypopituitarism, the most likely clinical presentation is a newborn who is normal birth weight and height, because, of course, growth hormone is not operative at first. Insulin is in the perinatal period, and then a decreased growth velocity over the first year of life. In the first weeks of life, we often see neonatal emergencies due to combination of thyroid and adrenal deficiencies. So there is severe hypoglycemia, other signs and symptoms of hypothyroidism, possibility of seizures, mineralocorticoid deficiency, so that the patient over the first 2 to 3 weeks becomes progressively hyponatremic. The intravascular volume and tone goes down, blood pressure goes down, patient develops acidosis, hyperkalemia, may even have arrhythmias. This would be the same type of presentation that we will see in an undiagnosed male, typically with 21-hydroxylase deficiency, salt-losing form. The patient also has, most profoundly, at birth at least, from a clinical standpoint, hypogonadism. Boys will have a microphallus with various dysmorphic features. Girls, however, still look normal. So that the key to a diagnosis in a boy, then, as close to birth as possible, is typically the presentation of a microphallus with small testicles or perhaps bilateral cryptorchidism and a combination of dysmorphic features, as the other findings, as I stated, certainly may not be evident right at birth, but would develop at least over the next few weeks. Now, acquired hypothyroidism, which is typically due to a craniopharyngioma most commonly, would be in a child who is an older child or at the beginning of adolescence, and they will present then with severe growth failure first. That is a significant decrease in the growth velocity due to the growth hormone component of this. And then the findings of hypothyroidism, hypoadrenalism, and then lack of sexual maturation if they haven't started puberty yet, or regression if puberty has started. And the big finding here would be in girls with either primary or secondary amenorrhea. They can also present with early findings of diabetes insipidus. If it is caused by a tumor, they'll eventually present with central nervous system findings after the initial growth failure, and these may be a combination of headache, papilledema, cranial nerve palsies, and visual disturbances. In all patients, the bone age is delayed if we were to obtain this. However, the best endocrine screening test is to draw blood for the insulin-like growth factor 1 and its binding protein levels matched to the bone age, and the value should be decreased based on the bone age. The best confirmatory test, then, is a growth hormone stimulation test. The safest method, which we see endocrinologists using, is to give IV arginine and then perform blood growth hormone level thereafter. Normally, there should be a significant rise in growth hormone levels with stimulation. This will, of course, not occur with the deficiency. With this, then, we can test all the other hormones for multiple hormone deficiency: thyroid-stimulating hormone, T4, cortisol, ACTH, luteinizing hormone, follicle-stimulating hormone, prolactin, and the gonadal hormones. The overall best test is the MRI, looking for any associated anatomic lesions, anatomy of the pituitary and hypothalamus, the presence of any space-occupying lesion, particularly, again, with acquired hypopituitarism. With isolated growth hormone deficiency, the treatment of choice is growth hormone therapy, and then also with whatever other hormones are necessary, depending on the evaluation of more broad pan-hypopituitarism. But with respect to growth hormone therapy, we will start with human recombinant growth hormone. As soon as the diagnosis is made, this is typically given subcutaneously at home 6 to 7 days per week until the growth chart shows that the growth is slowing and the bone age is at least greater than 14 years of age in girls and 16 in boys. Growth hormone replacement in the United States is also currently approved for Turner syndrome, Prader-Willi syndrome, intrauterine growth restriction with any lack of catch-up growth at 2 years of age, end-stage renal disease if the plan is a transplantation, and idiopathic short stature, that is, height less than 2.25 standard deviations below the mean predicted adult height at the 5th percentile. Potential complications with recombinant human growth hormone in the long run are leukemia, but this usually occurs with other risk factors in addition, increased risk of type 2 diabetes, development of hypothyroidism or adrenal insufficiency, gynecomastia, pseudotumor cerebri, and joint abnormalities, particularly worsening scoliosis. Anytime any other lesion or syndrome is caused for hypopituitarism, anything that can be corrected, the definitive therapy would, of course, do that correction. That is, let's say, treat a tumor in some way that might be responsible for the findings. Primary pituitary hormone secretion in children is rare. Most forms of hyperpituitarism occur from pituitary adenomas in terms of primary pituitary disease. The prolactinoma is the most common pituitary tumor of adolescents. We can also have a corticotropinoma, which is the most common prepubertal adenoma and is ACTH producing. You can also have a somatotropinoma. The more common reason for increased secretion of any pituitary hormone, however, is secondary. That is, the primary problem is in the target gland with a normal physiology of negative feedback. With increased growth hormone production from a somatotropinoma or due to any other causes that might be associated with that, we'll have continued open epiphyses, which will lead to gigantism. And if the epiphyses close and this continues, then acromegaly. The clinical findings are a significant acceleration of the growth velocity with possible behavioral and visual changes and other findings suggestive of a central nervous system lesion. Most adenomas then occur around the start of puberty. Many are due to the McCune-Albright syndrome, which represents autonomous hyperfunctioning of many glands due to activation of cyclic AMP receptors, resulting in tall stature, precocious puberty, abnormal skin pigmentation, and skeletal fibrous dysplasia. The best initial screen for any form of hyperpituitarism is a serum insulin-like growth factor and binding protein. The age-adjusted values will be increased. The confirmatory study is an oral glucose suppression test with administration of glucose and then checking a blood growth hormone level thereafter. The suppression will not occur, which is the normal physiology. For the causative lesion, as usual, the best test is an MRI of the brain. For tumors, they are typically removed if necessary by transsphenoidal surgery, but this may not lead to a complete cure. If growth hormone levels are not normalized, then typically radiation therapy is added, in addition to some somatostatin analog. As I said, prolactinoma is the most common pituitary tumor of adolescents. It's more common in girls. The clinical findings are headache, visual deficits, particularly with large tumors. In girls, we can have amenorrhea, and the principal finding, whether it's a girl or a boy, is galactorrhea. They may also have findings suggestive of more global hypopituitarism in conjunction with this, particularly with respect to growth hormone deficiency, or even hyperpituitarism with an increase in growth hormone and or an increase in TSH. It is important then to consider the difference in boys with physiological gynecomastia versus those boys who truly have a prolactinoma. Gynecomastia is defined as breast tissue in a male, and this is a common finding. Pseudogynecomastia is just due to adipose tissue, and we see this more commonly in overweight boys versus true gynecomastia, which is glandular breast tissue, and that represents the imbalance of estrogens to androgens. At the start of puberty, this may be present with asymmetric or symmetric and often tender enlargement of the breasts, which can last up to about 2 years. The only finding that we look at from an endocrine standpoint is a decreased ratio of testosterone to estradiol. And we typically don't do anything about this other than just following it, except in some rare cases of severe persistent cases when emotions are involved, when there is a large amount of breast tissue and the boy feels badly, we might consider an anti-estrogen drug or rarely surgery. There are other possible causes of gynecomastia, which are uncommon. Most occur in families. However, they can occur with hyperthyroidism, adrenal steroid defects, or even an exogenous source of estrogen. The key point is to determine that there is or is not galactorrhea. And it is only presence of galactorrhea then that will define the presence of a prolactinoma. The diagnosis is made with increased serum prolactin level, and then specifically the best test would be the MRI of the brain looking for the lesion. Most children respond well to bromocriptine, which is a dopamine agonist, or the long-acting drug cabergoline. Precocious puberty now is defined as the onset of sexual development in a girl before 8 years of age and in a boy before 9 years of age. We can have incomplete or partial precocious puberty, which we'll talk about momentarily, or for the current discussion, what is known as true sexual precocity. And true sexual precocity can either be central precocious puberty or peripheral precocious puberty. Central precocious puberty, for the most part, is usually sporadic or familial, and in girls particularly, idiopathic. Boys, however, commonly have a central nervous system lesion. Girls more commonly have initial anovulatory cycles with advanced height, weight, and skeletal maturity, as you would see in normal timing of physiological puberty. But because of the early onset, then, they're going to be prone to have early epiphyseal closure and ultimate stunted adult height without any treatment due to the advancement of the bone age. With acquired lesions, the most frequent lesion, particularly in a boy, is the hypothalamic hamartoma. This contains gonadotropin-releasing hormone-secreting neurons. Also, other lesions that can cause this are any hypothalamic lesions or anything that results in damage to the hypothalamus and pituitary, such as irradiation. Besides the findings of precocious puberty, they may present with findings of a central nervous system tumor, and with these tumors we have an increased incidence of seizures. They may also present with diabetes insipidus. We don't really need to discuss the significantly less common peripheral lesions causing precocious puberty, except to say that most of the causes are gonadotropin-secreting tumors and certain syndromes. The best initial screening test is the finding of an increase in LH and FSH with increased levels of serum testosterone in boys and estradiol in girls. The definitive test by an endocrinologist then is a gonadotropin-releasing hormone stimulation test, which then in the abnormal situation leads to significant increase in luteinizing hormone in boys. Luteinizing hormone, however, may remain low in girls, so in girls the best test is to stimulate with the gonadotropin-releasing hormone analog leuprolide and then obtain a serum estradiol level, which will always be elevated in abnormal physiology with any form of precocious puberty. In general, MRI should be done whenever there's a possibility of an acquired lesion, and for the most part, endocrinologists agree that this is always done in boys, but they don't agree in terms of automatically doing the MRI in girls, where, again, is most likely to be idiopathic or familial. The treatment then is with gonadotropin-releasing hormone agonist. The drug of choice is leuprolide acetate, which desensitizes the cells to the effects of endogenous gonadotropin-releasing hormone and stops pubertal progression and height and skeletal advancement, with the outcome of having an increase in adult height. Sexual features regress and the hormones return to prepubertal levels with this. Now, why would leuprolide do this, which is gonadotropin-releasing hormone analog? Because endogenously, the effects of gonadotropin-releasing hormone are due to its pulsatile activity. However, when we give this depot form of the drug, leuprolide, it's given once about every 3 to 4 weeks as an injection, and the levels stay up constantly. That is, you lose the pulsatile nature, and this is why the desensitization occurs. So the most important reason then that we treat precocious puberty, whether it's just physiological or pathological, is not just to stop the pubertal development, because ultimately these boys and girls are going to look the way they do anyway, except with a later onset of the findings. The main reason then that we treat is because we want to preserve adult height by keeping the bone age where it should be and allow the epiphyses to remain open. Incomplete precocious puberty occurs in one of three forms: premature adrenarche, which is the early onset of sexual hair due to earlier than normal maturation of adrenal androgen production, and with this there are no other changes in sexual maturation. Child may have a somewhat advanced height and skeletal maturation, but in general no treatment is needed. This tends to be familial, and as long as there are no other findings of sexual precocity, all we would do is follow the child. Second, premature telarchy is early breast development in girls. The most common presentation of this is in the neonatal period with regression over the first years of life. This is either familial or sporadic. There are no other signs of sexual maturation, and there are normal, that is, undetectable levels of LH and FSH. Later on, after 3 years, it would be the presentation of premature telarchy would be more consistent with true isosexual precocity, in which case it needs to be evaluated. It can also be due to exogenous estrogens or even a functioning follicular cyst. And extremely rare then is the onset of menarche too early, premature menarche. This may be idiopathic with few episodes and then normal pubertal development and menstrual cycles. However, most prepubertal vaginal bleeding should be thought of as due to other causes. For instance, trauma, foreign bodies, sexual abuse, or even uncommonly tumors such as the botryoid rhabdomyosarcoma, which is that tumor that looks like a cluster of grapes. Vignette. A 2-month-old patient appears to be having inadequate weight gain. His mother states he is constipated. On examination, he has decreased muscle tone, large fontanelle, large tongue, and an umbilical hernia. Congenital hypothyroidism tends to be sporadic or familial. The most common cause is thyroid dysgenesis, that is, either hypoplasia, aplasia of the thyroid, or an ectopic gland. More commonly, it is sporadic, more common than familial. But we can also see biochemical defects in thyroid hormone synthesis with or without a goiter. Any of the enzymes and the pathway to thyroid hormone can be affected in an autosomal recessive manner. Other causes are transplacental passage of thyroid autoantibodies from maternal autoimmune disease, and this then will present as transient congenital hypothyroidism, usually over 3 to 6 months of the infant's life. It can also occur because of radioiodine administration during pregnancy by mistake, maternal iodine exposure for some reason, or uncommonly because of central hypothyroidism due to a thyrotropin-releasing hormone or TSH deficiency. Neonates are usually asymptomatic at birth because of transplacental passage of moderate amounts of T4, but still significantly decreased for neonatal screening diagnosis. So this is how the diagnosis is made at the earliest time, is with our neonatal screening programs. And then signs and symptoms develop over the first weeks to months of life. The initial findings are prolonged physiological jaundice due to delayed maturation of glucuronidyltransferase and abnormal liver function, widely patent fontanelles, particularly the posterior fontanelle and the cranial sutures, and therefore an increase in head circumference, also due to brain myxedema. Other findings of hypothyroidism develop more slowly. There can be lethargy with increased sleep, poor feeding, decreased appetite, constipation, decreased crying, and the suggested physical findings are a large protruding tongue, generalized hypotonia, presence of an umbilical hernia, cold mottled skin, edema, coarse brittle scant hair, and decreased temperature and heart rate. Long-standing untreated hypothyroidism, that is 3 to 6 months, may result in significant growth failure, developmental retardation, including mental retardation, delayed tooth eruption, anemia, and even heart failure. While all of the physical findings are correctable with thyroid hormone, any developmental or cognitive findings are permanent, and they need to be dealt with in terms of developmental therapy and special education. Acquired hypothyroidism in children is most commonly due to chronic lymphocytic thyroiditis. that is autoimmune or Hashimoto thyroiditis, and they may be associated with the type 1 or type 2 polyglandular syndromes. There's an increased incidence of this in Down syndrome, Turner syndrome, and Klinefelter syndrome. Other causes which are not common includes medications containing iodides, radiation, surgery, histiocytosis, or even cystinosis. Autoimmune thyroiditis occurs with antithyroglobulin, antiperoxidase, and thyrotropin receptor blocking antibodies, which leads to gland hyperplasia. We see infiltration with lymphocytes and plasma cells, hence its name, and this all results in follicular atrophy. So the patient may present as a goiter, which may be euthyroid or hypothyroid, and these tend to be diffuse, firm, and non-tender, or they can present as atrophic hypothyroidism. This disease is twice as common in girls and most commonly presents in early adolescence, but can appear at any age in childhood. There may be familial cases, primarily with an autosomal dominant transmission, particularly in males where we see decreased penetrance. The first sign of clinical presentation is decreased growth velocity and also delayed bone age, with or without a goiter. And then the common signs and symptoms of hypothyroidism, such as lethargy, increased need for sleep, constipation, cold intolerance, increased weight, skin myxedema, muscle weakness. And again, with severe long-standing disease, you can have neurological findings, an ileus, adrenal insufficiency, heart failure, respiratory failure, and multiple other problems, including other endocrine findings. Again, for congenital hypothyroidism, the neonatal screen is necessary. The neonatal screen measures T4. A low T4 will identify primary hypothyroidism. Some patients with central hypothyroidism, that is TRH or TSH deficiency, may not be diagnosed in this manner. Thyroid hormones then, which should be done next after the neonatal screen, will show a decrease in T4 and free T4 with an increase in TSH for primary hypothyroidism, and of course, rarely for central, a decrease in TSH, T4, and free T4. A radionuclide scan is typically done thereafter to determine whether this is caused by thyroid dysgenesis or due to a synthetic defect. If we see a normal size gland in the correct location with an increase in uptake, then this is going to be normal anatomy and will be due to one of the autosomal recessive biochemical defects. Specifically, genetic studies can be performed then to detect the specific defect. The treatment is oral levothyroxine, which returns the thyroid hormones to normal and suppresses the TSH to a normal range. Growth will then catch up, and normal growth indicates adequate therapy. Early diagnosis and treatment for normal growth and intelligence and prevention of irreversible brain damage is necessary. The same treatment essentially is done with the diagnosis of Hashimoto's thyroiditis. T4 and free T4 in this case may be normal or decreased, but there will always be an increase in TSH and, when tested, the presence of antithyroid antibodies. Levothyroxine is used if the patient is clinically hypothyroid. Labs must be followed, as the disease may in some cases be self-limiting. The goiter size will decrease if there is one, but it does persist to some degree at least for years. Also, the antibodies vary and also persist for years. Vignette. A 12-year-old girl has a 6-month history of hyperactivity and declining school performance. Appetite is increased, but she shows no weight gain. Physical examination reveals a slight tremor of the fingers, mild exophthalmos, and a neck mass. Almost all cases of hyperthyroidism in children are due to Graves' disease, due to the autoimmune production of thyroid-stimulating antibodies leading to a diffuse toxic goiter. However, in the neonate, we may also see transplacental antibodies from the mother, giving the transient appearance of Graves' disease in the neonate, typically between 6 weeks and 4 months of age. Other causes are much less common. Because of the autoantibodies, which are stimulatory, the patient typically presents with a diffuse goiter, generalized hyperplasia of lymphatic tissue, and of the retroorbital tissue of the eyes, leading to exophthalmos. Girls are affected much more commonly than boys. The most common time of presentation is early to middle adolescence, with the development of gradual symptoms, first starting with emotional lability and motor hyperactivity, that is tremors, restlessness primarily, Then decreased sleep, increased appetite and eating, but with weight loss, which is a key to making the diagnosis, and decreased school performance. Thyroid size is variable, as are all of the findings. The skin may be flushed with increased sweating. There may be cardiovascular effects, for example, tachycardia, palpitations, arrhythmias, and even heart failure. If there's an acute outpouring of thyroid hormones, this leads to what is called a thyroid crisis or thyroid storm, which is a sudden increase in temperature, severe tachycardia and heart failure, and seizures, which, if untreated, may lead to coma and death. The diagnosis is made by finding increased T4 and free T3 and a decrease in TSH with positive autoantibodies. And again, almost all have thyroid stimulating antibodies present. The primary treatment is still with antithyroid drugs. Radioiodine ablation is used in some children over 10 years of age, but the drugs are either methimazole, which may be associated with less adverse effects in children. It also has a more potent and longer half-life, so that only once a day dosing is required. Or with propethyluracil, PTU, which requires 3 times a day dosing and is less protein bound, so it crosses the placenta and into breast milk. Radiotherapy or subtotal total thyroidectomy is indicated for suboptimal response. For severe initial symptoms, that is the thyroid crisis, a beta blocker like propranolol is needed for sympathetic blockade in conjunction with IV fluids, often with glucocorticoids and even digitalis, and then the treatment as just discussed. Primary hypoparathyroidism is uncommon in children. It is most seen in the neonatal period because of functional immaturity of the parathyroid gland in the first days of life. So we particularly see clinical effects of this in preterm infants, sick infants, infants of diabetic mothers, and it can, depending on whether you have a term infant, well infant, preterm infant, sick infant, it can present anywhere then from transient mild asymptomatic hypocalcemia to symptomatic hypocalcemia in the very small or sick infants. Like other autoimmune disease, in the newborn we can see suppression of neonatal parathyroid hormone, PTH, by maternal hyperparathyroidism, in which case the patient may have transient hypocalcemia, but these certainly may be symptomatic. In infants and older children, then, the most common cause is parathyroid aplasia or hypoplasia, such as the DiGeorge syndrome and other 22q11 deletion syndromes, the Catch-22 syndromes. And then there are much less common forms that are inherited in various genetic ways, plus biochemical defects and autoimmune hypoparathyroidism. It's important, however, to determine whether or not there are other causes of hypocalcemia, including, very importantly, nutritional deficiency, which could lead to rickets, magnesium deficiency, which impairs the release of parathyroid hormone and leads to hormone resistance, increased inorganic phosphate, for instance, from laxatives, enemas, inorganic phosphate poisoning, or even early in the treatment of acute lymphoblastic leukemia, and very, very importantly, vitamin D deficiency. The primary presentation is muscle pains, cramps, paresthesia, carpal pedal spasm, Schwastek sign, Trousseau sign, and even seizures. In long-standing cases, before the diagnosis is made, we may have the development of cataracts, tooth abnormalities, including delayed eruption, and mental deterioration. The diagnosis is made by finding low serum calcium, and therefore low ionized calcium, increased serum phosphate, low to normal alkaline phosphatase, and a low 125 dihydroxy vitamin D3 with normal magnesium and a low PTH. Emergency treatment, that is for neonatal tetany, is IV 10% calcium gluconate while monitoring the heart rhythm, plus starting calcitriol orally, which is the oral 125 vitamin D2, and then on a longer-term basis, oral calcitriol plus supplemental calcium and adequate dietary calcium intake. The most common cause of rickets in the United States is vitamin D deficiency, and this is usually due to a combination of poor intake and inadequate cutaneous synthesis. The most common findings are abnormalities of the extremities, including valgus or varus deformities, tibial femoral bowing, wrist and ankle enlargement, the rachitic rosary, craniotabes, frontal bossing, craniosynostosis, delayed fontanelle closure, delayed dentition, kyphoscoliosis, fractures, and any symptoms of hypocalcemia. X-rays are required, and the typical radiographic findings are thickening of the growth plates, widening of the distal metaphyses, the wrists and the ankles, metaphyseal fraying due to a loss of a distinct border, metaphyseal cupping, the metaphysis becomes flat or concave, and this is best seen at the distal ends of the radius, ulna, and fibula, and plus the finding of the rachitic rosary. Because of the vitamin D deficiency, this then will be the most common cause of secondary hyperparathyroidism. That is, the primary problem leads to a significant increase in parathyroid hormone, which then allows for anywhere from a normal to low calcium, but significantly decreased serum phosphorus, because in the presence of an increased PTH, we have increased renal losses and decreased intestinal absorption. The alkaline phosphatase is typically increased. 1,25-D2 is decreased with severe deficiency because 1-alpha hydroxylase is upregulated. Initial replacement is with vitamin D and calcium, and then maintenance therapy with vitamin D and calcium is necessary with adequate dietary calcium and phosphorus. Vignette. A 1-month-old infant is seen with vomiting and severe dehydration. Physical exam reveals ambiguous genitalia. Laboratory tests show hyponatremia. Of the various forms of congenital adrenal hyperplasia, the most common, representing more than 90% in children, is the 21-hydroxylase deficiency. 21-hydroxylase is required for the synthesis of cortisol and aldosterone. The most common presentation, and unfortunately the most severe, is the salt-losing form because of the hypoaldosteronism. The rest of the patients, smaller number of patients, can synthesize aldosterone and therefore are not salt-losing. The salt-losing plus the non-salt-losing forms together are called classic 21-hydroxylase deficiency. The non-classical form, which represents only a small number, leads to a mild increase in levels of androgen. The precursor to the block at the cortisol pathway is the precursor 17-hydroxyprogesterone. This accumulates just prior to the block and is the cause then of shunting into androgen pathway with increased androstenedione and testosterone from 8 to 10 weeks gestation. Because of this, of course, the outcome is virilization to various degrees in the female, with clitoral enlargement, partial to complete labial fusion, and urogenital sinus development. Females, of course, have ovaries and normal internal organs, including fallopian tubes and uterus. In the undiagnosed patient with the salt-losing form, that is most likely going to be a male, because males look entirely normal at birth, and if it's the first male in the family, first baby in the family to present with 21-hydroxylase deficiency, again, it's not known that the gene is present. These will then present as primary adrenal deficiency over the first few weeks of life, which we have already described. The findings would be worsening hypoglycemia, hyponatremia, hyperkalemia, acidosis, and because of the salt loss, a depletion of the intravascular volume, hypotension. These patients also have progressive vomiting, disinterest in feeding, and lethargy. Females will have varying degrees of masculinization because of the virilization. If the non-salt wasting form is not treated for some reason, then there would be progressive androgen effects after birth. And this would result in increased velocity with skeletal maturation, which we've talked about previously, resulting in precocious puberties in males, and further masculinization in females with no breast development or menarche unless treatment is begun. So if the diagnosis is not made at birth with a classic female patient with ambiguous genitalia, then the onset of the salt wasting form is going to be evident over the first weeks. The presence of hypoglycemia, hyponatremia, hyperkalemia, and acidosis should lead to the immediate check of 17-hydroxyprogesterone, which will be increased. Further testing would then show decrease in cortisol, increase in plasma renin activity, and decrease in aldosterone, increased androstenedione and testosterone. The best test, however, is to measure 17-hydroxyprogesterone before and after an IV bolus of ACTH, after which there would be a large increase in 17-hydroxyprogesterone. Prenatal diagnosis can be formed by chorionic villus sampling at 10 to 11 weeks for those who have already had a child with 21-hydroxylase deficiency. And in a number of states, we perform the newborn screen for this. It does measure 17-hydroxyprogesterone, but there are a number of false positives, and therefore values need to be retested at 2 weeks after we have a positive screen. The treatment is daily hydrocortisone for the cortisol deficiency, and if mineralocorticoid deficiency is present, the addition of fludrocortisone as well, plus any sodium supplementation if needed. The most important overall therapy then involves females who have been masculinized. Again, this can be from a lesser to a greater degree, and this involves a multidisciplinary team because corrective surgery is then needed, both gynecological and urological. Cushing's syndrome is caused either by hypersecretion of ACTH by the pituitary, and in this case we refer to this as Cushing disease, or of glucocorticoids by the adrenal or even exogenously. In endogenous Cushing syndrome, we see this most in infants from a functioning adrenocortical tumor, and most of these are malignant carcinomas. Fewer are benign adenomas, but it leads to increase in cortisol, aldosterone, androgens, and estrogens. Cushing disease, on the other hand, in an older child, is most commonly caused by a pituitary adenoma. This may be a microadenoma, and at least initially difficult to find. And this is found most commonly in children older than 7 years of age, who because of this have bilateral adrenal hyperplasia. Less commonly, we see Cushing syndrome from an ectopic production of ACTH, for instance, from a neuroblastoma, a Wilms tumor, a ganglioblastoma, as well as others less commonly. It may also be part of the MEN1 syndrome. In any form, the most common clinical findings are moon phases, generalized obesity, abdominal striae, decreased growth velocity, delayed pubertal changes, in a girl amenorrhea, hypertension, androgen effects such as hirsutism, acne, deepened voice, phallic enlargement, hyperglycemia, increased incidence of infection, osteoporosis leading to pathological fractures, and non-specifically headache and weakness. The diagnosis is made based on the loss of cortisol circadian rhythm. So the best screening test is a single-dose dexamethasone suppression test. If it's given at 11 p.m., there will be no decrease in the 8 a.m. cortisol measurement. To determine the etiology, the endocrinologist will give an IV bolus of corticotropin-releasing hormone, CRH. With an ACTH-dependent Cushing disease, there will be a large increase in the ACTH and cortisol, but with adrenal tumors, there will be no increase. After this, a CT scan is the best initial study of the adrenals looking for a tumor, and an MRI with contrast of the brain for a pituitary lesion. The contrast, again, because the lesion may be otherwise small and difficult to see. Treatment is primarily transphemoidal pituitary microsurgery. This is the treatment of choice for pituitary adenomas. With an ACTH-secreting metastatic tumor, the adrenal or adrenals should be removed. For unilateral benign cortical adenoma, removal of the adrenal is all that is necessary. If it's bilateral, then bilateral subtotal adrenalectomy is necessary. Most children with diabetes will have type 1, which is autoimmune destruction of the pancreatic beta cells, leading to low to absent levels of endogenous insulin. There is a genetic susceptibility to this, primarily increased with certain HLA types, and it occurs in association with other autoimmune disease. The onset is mostly during childhood with a peak in adolescence, and it is felt that there are often environmental triggers, whether they be dietary, infectious, chemical, plus an addition of factor of psychosocial stress. The pathophysiology is the presentation of a catabolic state with low insulin levels. This leads to decreased utilization of glucose by muscle and fat, and increase, therefore, in postprandial hyperglycemia. With further autoimmune destruction and decreasing insulin levels, we have increased hepatic glycogen breakdown and gluconeogenesis, which leads to fasting hyperglycemia. When the serum glucose concentration is greater than the renal threshold for glucose absorption, typically around 180 milligrams per deciliter, then an osmotic diuresis ensues, and this leads to dehydration, electrolyte abnormalities, and the loss of calories. Counter-regulatory hormones are secreted, that is glucagon, growth hormone, cortisol, epinephrine, and more glucose production ensues, with an impairment of insulin secretion, accelerated lipolysis, and less lipid synthesis. Fatty acids then become used for fuel and are metabolized to ketone bodies, which accumulate to produce a metabolic acidosis and are excreted in the urine. So the most common presentation in children is diabetic ketoacidosis with this pathophysiology. The initial presentation is intermittent polyuria and nocturia, then more persistent polyuria with polydipsia. Loss of calories in the urine leads to polyphagia, loss of weight, and body fat. With very low insulin levels and continuation of the pathophysiology, as stated, DKA ensues, and this presents with nausea, vomiting, abdominal pain, weakness, dehydration, orthostatic hypotension, Kussmaul breathing, and a fruity breath because of the presence of acetone. Diagnosis is made with the classic symptoms plus a non-fasting blood glucose at any time of greater than 200 milligrams per deciliter, with or without ketonuria. In diabetic ketoacidosis, there will be electrolyte abnormalities, and most importantly, an increased anion gap metabolic acidosis, hyperosmolality, and ketonuria. Other glucose findings include a fasting blood sugar of at least 126 milligrams per deciliter, or rarely anymore will an endocrinologist do an oral glucose tolerance test. However, if this is done, a 2-hour value on that test of at least 200 milligrams per deciliter. Initial management of diabetic ketoacidosis involves a continuous infusion of insulin in order to decrease the hyperglycemia. Also, the patient needs to be rehydrated because of the osmotic diuresis. The metabolic acidosis is correct. Ongoing sodium loss is stopped and sodium returns to normal. Potassium loss is stopped and potassium returns to normal. And phosphate loss is stopped as phosphorus returns to normal. The subsequent therapy involves replacement insulin, usually in combination with long-acting analogs and rapid-acting bolus insulin analogs. Most patients at first have a residual beta cell function called the honeymoon period, with a gradual increase then in requirements over the next few months. Insulin changes are typically based on self-monitoring, and the most accurate dosing is achieved with carbohydrate content of meals in conjunction with performing blood glucose levels. Self-monitoring of blood glucose is necessary at least 4 times a day, prior to meals and at bedtime, when starting on insulin and with any adjustments. Ideal values are now felt to be 80 milligrams per deciliter fasting glucose to 140 milligrams per deciliter after meals. Generally, values between 60 to 220 milligrams per deciliter are felt to be acceptable. A good method of determining control is with the hemoglobin A1C, that is the glycosylated hemoglobin. This represents the fraction of hemoglobin to which glucose has been non-enzymatically bound. Increased values are correlated to higher serum glucose levels for longer periods of time and represent average glucose concentration for the preceding 2 to 3 months when a value is drawn. Good levels are felt to be between 6 to 7.9%. Nutrition is very important. Total calories on a daily basis are based on surface area from standard tables. The ideal distribution is 55% carbohydrate, 30% from fat, and 15% from protein. Most of the carbohydrates should be complex with a limitation of sucrose and simple sugars. We also use a diet high in fiber and low in the ratio of polyunsaturated to saturated fatty acids. Carbohydrate counting is used to adjust the insulin dose, and meals are planned based on groups of food exchanges. Calories from each meal should be 20% from breakfast, 20% from lunch, 30% from supper, and 10% from each of 3 daily snacks. And finally, exercise is important as well. Any type of exercise is allowed, but is limited at any time by the development of hypoglycemia. Regular exercise provides better glucose regulation. There is a need, however, for additional carbohydrate exchange prior to exercise and available glucose during and after any exercise period. If there are any episodes of hypoglycemia, the insulin dose on the day of exercise should be decreased. The current American Academy of Pediatrics recommendations for screening children for type 2 diabetes include an overweight child, that is, a child of any age and sex who has a body mass index BMI greater than 85%, at 10 years of age or at the onset of puberty, whichever is first, plus they have any two of the following. 1, a family history of type 2 diabetes in first or second degree relatives. 2, high-risk race or ethnicity, that is from non-white Americans, being again Hispanic Americans, African Americans, Asian Americans, Native Americans, or Pacific Islanders. And thirdly, signs of or conditions associated with insulin resistance, that is, any of the findings of the metabolic syndrome. They should be screened every 2 years with a fasting blood sugar. This is the preferred method. As before, the diagnosis is made either for impaired glucose tolerance, that is, we have a fasting blood sugar of 110 to 125 milligrams per deciliter, or a 2-hour oral glucose tolerance test of at least 140 but less than 200 milligrams per deciliter. And for the diagnosis of true diabetes, then, symptoms of diabetes plus a random plasma glucose of 200 milligrams per deciliter, fasting blood glucose of at least 126 milligrams per deciliter, or 2-hour oral glucose tolerance test of at least 200 milligrams per deciliter. The first and most important element of treatment is nutritional education and improved exercise level to increase physical activity and weight loss. Insulin is required at the diagnosis with findings of dehydration, very high glucose levels with ketoacidosis, ketonuria, and usually this is only necessary for a few weeks. We now know that the vast majority of children who have early onset diabetes will develop diabetes type 2 early in adulthood, and oral hypoglycemics are now used also. The only oral hypoglycemic agent that is FDA approved are primarily metformin, which is the biguanide, and this is the preferred drug, and secondarily glimepiride, which is a sulfonylurea. So with a diagnosis or after the initial insulin therapy, we start with metformin, which decreases hepatic glucose production. Remember, it's contraindicated with any significant hepatic or renal disease. It often results in weight loss. If control is not achieved, then glimepiride is added, which may cause weight gain. And if there's still lack of control, the generalist needs to refer to an endocrinologist, and now the preferred drug is insulin at this point, and then the patient is followed from that point on.